this actually is quite relevant. Neil and I are really diving in. So I'm going to modify this talk to be more to you guys. And if anyone else calls in, let me know. But this is probably more of a discussion than a talk, really. And Meg, I've been sort of going back and forth on actually when to get you involved in this development. And the development involves investigation immunology of our immune-directed technologies. And in that investigation, we're going to want to bring in certain products that relate to weak points of technology we have, or that assist in same ways where we found some technologies to have strong points. It also may lead to identification of further parameters in patients. On one hand, we have the molecular signal profiles where we're looking for molecular targeted therapeutics. And what Neil and I are working on is creating specific profiles that would potentially be associated with immunotherapies. And I think, Megan, you're very aware of the tumor mutation burden relationship, but we're looking deeper into that and trying to see specifically what antigens based on the tumor mutations and what TCR receptors based on what we're eventually going to start doing is TCR expression analyses on patients' circulating cell counts to try to understand what may be relevant neoantigens. So in all honesty, with the three of us on this, I'm not going to be doing too much to tell Neil what this is all about, but Megan, I'll at least sound intelligent to you, I think, a little bit. So you and I, Megan, have to hope that Neil will. And what I wanted to go over was to focus on the relationship of tumor-specific neoantigens and self-antigens. And Neil, as I'm going along, I mean, I'm, to educate me, to come in there and, hey, this is how you think of it. This is a discussion. So Neil, anytime you want to interrupt and clarifying things and stuff like that, because this is only going to make Megan and I better. But the point is that one of the things that, Meg, you probably know, but the way I think of it is if we can identify an immunotherapy that would specifically target the neoantigens, these are the antigens that are related to tumor mutations, and these are the ones that are exclusively limited to the tumor cells. We're going to have therapies that would potentially attack tumor cells, but not attack normal cells. And as we've learned over time in developing many immunotherapies, probably some of the toughest ones being related to IL-2, IL-1, there's a lot of toxic effect. And some of this toxic effect is potentially related to off-target activity against self-antigens on normal cells. The PD-L1 inhibitors have some level of this being induced as well. So in an immunotherapy, one of the focuses is going to be to try to find a way of maximizing the activity against the tumor-specific neoantigens, how to characterize that, and how to maximize that with many of these therapies. So some of this comes from Neil. Louisa has helped develop some of these slides, and I've added some in. But one thing that we know, if you go on to the next slide, slide 3, is that there are many reasons why mutations occur, but there's a very common, there's a consensus-driven knowledge that mutations increase over time in our bodies. These cells that develop mutations sometimes are transient, other times they persist, and eventually a tolerance will develop the body's immune system to cells with these mutations. And if the mutations affect an area where it enhances cell growth or progression, they develop qualities of malignant cells, then you have a cancer developing. And that's why you see oftentimes cancer occurring, generally over age 60 in patients. It can occur earlier, and we'll get into a little bit of that. But on the next slide, slide 4, there's also a breakdown of mutations associated with cancer and the occurrence of high frequency of mutations in various cancers and the relations of certain cancers. And if you look at the cancers on the top of the list on the right on this slide, you can see melanoma, lung, you see colorectal up there, bladder cancer, stomach or gastric. bottom line is these are the cancers that are initially demonstrating sufficient activity with immunoresponsiveness to the checkpoint inhibitors and have received already in many of these FDA approval. So I think there's increasing relationship of sensitivity in high mutation counts to at least PD-L1 based therapies. If you look on slide 5, this is work done.
John, going back to slide 4 for a second.
Yeah,
you know, one of the things worthwhile pointing out is that over on the left, you tend to have most of the pediatric tumors where, you know, these are, you know, they're young and they haven't had time to, you know, build up a lot of, you know, different mutations. And over on the right, the ones that have, you know, a significant amount of a tumor mutational burden and neoantigens are the ones that have been exposed to very known mutagens, you know, the sun with melanoma and smoking with adenocarcinoma, and, you know, the mismatch repair problems with the alimentary cancers. So you have a lot of mutations, especially involving repair pathways in the tumors on the right, to account for that high number of neoantigens.
Totally, absolutely right. So good points, Neil. So I agree. Then in formal registration product approval with Atezo, PD-L1 inhibitor, Rosenberg published and presented his data at ASCO just this year. Very high correlation of the high tumor mutation burden with low, both with respect to response and survival in that well-controlled trial. So there's no doubt, even though it still remains to be demonstrated in each individual cancer histology, I don't think there's any doubt that there's a high likelihood of correlation with any cancer type related to the tumor mutation burden, knowing the mechanism of this. This mechanism also appears to be independent of PD-L1 expression. So it's something that, as now Foundation Medicine keeps on their reports, we're using it in the clinic now, and it's quite exciting to identify technologies that may enhance that response rate in the high DMB patients, but also to identify technologies that may potentially rescue those patients who are perhaps better candidates for molecular therapy, or certainly who we'd want to give a attempt at combination immunotherapy if they have a low TMB count to see if that would make a difference. So work can be done where you need to separate the TMB level on patients as you move forward in the immunotherapy development field. So Neil, I don't know how much if you saw this data, but a couple of months ago, I asked our guys, Rachel and Megan and Leah, to put together a summary of the last 266 patients that underwent Foundation 1 testing, and get a summary from Foundation 1 on the TMB counts that they have, but this is before they posted it on their reports. And we found 27 that had a high TMB if you define it as 10, megabytes of DNA or something is the unit that they use. And when we looked at those 27 patients, 6 of them had gone on to immunotherapy trials at Mary Crowley, and this is the 6 patients who went on the trials. Of the other 21 patients, Leah's still looking for verification of the results of this, but only one of those 21 had evidence of response, whereas of the patients who did receive immunotherapy, all 6 of them had response as defined by some of the early publications correlating TMB with benefit. And that response was RECIST PR, RECIST CR, or stable disease for 6 months or more. So Neil, that's the definition of response I'm using to maintain our evidence of positive benefit. It did get into a number of publications, so I think that's not unreasonable as a first look. So I thought that was interesting. You can see the TMB counts of these patients. Generally, there's a correlation, according to Foundation Medicine data, that the higher the TMB, the more likely you'll have sensitivity. they had about an 8,000 patient database across tumor histologies and feel that it's across all cancer histologies. So a couple guys just walked in over here, guys, and what we're going into is the significance of targeting tumor self-antigens, the neoantigens, and tumor-specific neoantigens versus self-antigens. When you hit the self-antigens, you're hitting your own tissue. When you're hitting the neoantigens, you're hitting just the tumor tissue. And so we're going into the wealth of data that supports that as a significant factor. And then we just went into our Mary Crowley data, where we looked at the last 266 patients, I think it's over the last year, and identified 27 with a high TMB, and found 6 who went on to an immunotherapy in our program, and all 6 of them fulfilled the definition of response. If we look at the 21 patients who didn't get in immunotherapy in our program, one of them did have a response to a targeted therapy in our program, but none of the others had a response by the same definition. So 1 out of 21 versus 6 out of 6. So that tells me that it's worth us inside trying to link up the high TMB patients with immunotherapies. That's only going to be about 10 to 15% of your patient population. But it's certainly something that we want to look for if we have 2 studies and there's a choice of one or the other. The one thing that fell out that was kind of unusual, and Neil, we haven't gotten clarity on this yet ourselves, but I thought it'd be fun to talk about. It's in this talk in a little bit. Is on the bottom there's our Ewing's patient, Carly, basically, you guys don't know her, who also had a dramatic response. So I asked Rachel to go and track down the TMB on Carly, and I was totally expecting her to have a high TMB count. On one hand, the young UR-less mutations you're going to have, as Neil pointed out, as we showed in that age-related continuum of mutations developed in cancer. So it may be that she won't have many mutations because she's very young, but she did have a mutation that involves DNA repair. And so the DNA repair defects tend to have higher gene mutations. So we didn't know, but I thought since she had a response, I would have guessed that she would have a high TMB count. And when we got it back, it was 3, which is quite low. So then it's like, okay, so here everything's working, and sometimes you have exceptions, as we all know, but could there be another reason for a relationship of the TMB count or lack of relationship of her TMB count, which is low, to response, because she had a dramatic response. And so,
well, John, a reason for that is the TMB count by itself. You know, I think most of the people who have discussed it feel that the higher it is, the more likely that you are going to have a neoantigen present. We do know, for instance, that on the average, for every 16 passenger genes, you wind up having 1 driver gene. So the fact that as you get older, you do have a much greater, tumor mutational burden. Clearly, as an adult, you're more likely to have neoantigens. Since as a child, you haven't had that, the amount of time to accumulate these passenger mutations, you probably have a lower ratio of driver to passengers, so that even though you have a less of a total mutational burden, mainly because of the decreased number of passengers, you probably do have a higher proportionate number of those mutations that are capable of producing a tumor-specific response. Also, you can have a tumor-specific response with tumors that have, cancer testis antigens, which were the antigen, cancer testis antigens, which were antigens present on the germ cell line, because in the germ cells there's no HLA expression, so that is also sensed by the immune system as foreign. So keep in mind the total mutational burden is probably just a surrogate of the likelihood of having true tumor neoantigens. In and of itself, it probably doesn't mean much of anything.
Mm-hmm. Yeah, other than you're likely to have just what you said, that sort of immune-inducing mutation, which we are desperately trying to characterize what exactly those are to integrate it into therapeutic approaches. But as we go on with the story, we know that there may be another reason for her immunogenicity as we go along. Which we'll get to in a minute. So thanks, Neil. The next slide is simply what Leah's working on right now, is verifying the responses or lack of responses in the patients who didn't receive immunotherapy who had a high TMB count there. So before you guys came in too, we sort of changed the format to one of discussion. So Neil's really not just interrupting me to be rude. We're just, I said this is more of a small group so that even though I talk fast, butt in and come up with questions, issues, not sure about something, let's do it along the way. Sometimes I like to just get it presented and go, but here I'm thinking as we go along, because I'm going to relate back to Crowley, I'm going to relate back to patient experiences, I'm going to relate back to products you guys know. It's a good chance to either say what somebody asking or just write it to discussion. Okay, so that's.
Can I ask a question about Carly?
No, this is only applicable to the other guy.
Well, you mentioned that. I think initially she had the Ewing's defect.
So we're going to go into that in real detail.
Okay.
Yes, yeah. There's a really pretty slide. Okay. That's what me and Neil have been pulling our hair out the last couple of weeks. So yeah. So all right. So I'll get to that. So now we're trying to figure out why did Carly, along the lines of what Ned's saying, why is she hanging there, low TMB count, likely very small chance that she has, as Neil was saying, a 1 in 16 chance in a relevant mutation due to an immune response. But one thing we do know about her, she has this edocephalide fusion protein. And so if you start to look at that a little bit more closely, maybe, as Neil said, maybe it's not just related to the TMB. Maybe there's something the TMB is a surrogate of, as Neil stole my fire of, but the point is that you can have. And so here's a study done recently that in 2014 that took an edocephalide type 1 peptide and they pulsed dendritic cells with it. Okay, because you were yawning, that's what I was wondering. So they it's great, Neil, So these dendritic cells, what they do with the pulse peptides is they show them on their surface and they allow or enable or attract lymphocytes that have the ability to activate and develop receptors to those peptides, and in that process they become activated, and they basically get the ability to attack the tumor cells. And so what this group did is they pulsed these dendritic cells from mice, and immunostable mice, and they infused the dendritic cells, and they showed that indeed with the type 1 Ewing sarcoma on the next slide, you can actually induce tumor, and you can prolong the survival of these mice. If they had a non-relevant antigen, they used a hepatitis antigen. None of these mice had hepatitis. It wasn't a hepatitis, like a hep C based tumor. They showed no effect of it. So it showed the relationship of edocephalide fusion protein to the immune response and linked it to clinical benefit. So this is very good preclinical data that supports. Tasha. So that supports this possibility of why was Crowley an expression? Are we just wrong with the TMB, or is the TMB a surrogate or something? Okay, if it's a surrogate of something, what could it be? And is there anything else unique about her? And one obvious uniqueness is the fusion protein uniqueness. So on the next slide is basically what we're saying. I personally, when we started to look at Ewing sarcoma, one of the attractions was because the fusion protein is a clear driver gene, and so you guys are going to get experience with the trial in the next couple of weeks. I don't think the SIV is done yet of the nanoplex, the edocephalide type 1 nanoplex trial, the STRIKE trial. Yeah.
Oh, yeah.
So we had developed a study to look at the use of the bias H to knock down what's a clear driver gene in cancer. These are the genes that we know for sure stimulate the cancer growth. Likely were involved right in the beginning of that cancer cell becoming a cancer cell, have what appear to be oncogenic activities, So these are the big guy genes. A lot of the gene therapies that we're using, or the gene targeting therapies we're using now, we don't know for sure if they're driver genes. What we think they are, we know that they're related to prognosis in many of these patients. We've seen some responses in animal models, but there's still more to the driver gene aspect, and sometimes you have to compensate for what a driver gene is, and we may be targeting something downstream that has pathways around it. So that's why the concept you have to target multiple genes sometimes to make sure you block through, even though you don't know what the driver gene exactly is, if you're blocking the avenues by which it's coming down to stimulate the cancer growth, you still can create a significant anti-cancer activity. But with Ewing sarcoma, this fusion protein and the gene that generates it is clearly a significant factor in the cancer growth of that patient. You know what I mean? So, so the molecular therapy is developed for that, and we sort of forget about the immunotherapy. We actually, when we originally treated Crowley the very first time, Ewing sarcoma, I won't get into detail of it, but Ewing sarcoma was not thought of at all as an immunogenic tumor. In fact, there were reasons to believe it may be actually with a low immune sensitivity. So part of the reason we allowed her on the study at first was she had no other good options, was you never know, but because we wanted to understand what would be the reach of this immunotherapy in terms of turning on an ELISpot response. Could it actually work even on a patient where we might think wouldn't be as immunogenic? But on the other side, we're thinking she's a young kid. Young people have better immune responses than elderly people, except in you, Keish. You always keep yours good because you're so active. And so I'm just being honest. But you get it, that maybe the good immune system in a younger child, or maybe there's something else to it. So we allowed her on study, and lo and behold, she does well. But if you look at the next slide, on slide 11, you can see there's a wealth of fusion proteins. This is a slide that Neil actually made, and he presented in his prior talk. And I like to have these talks sort of follow up each other so you can learn, here's something, but then now here's a little bit more. And sometimes it's easier to understand talks that we may give when you sort of remember something from the prior one, we explain it, and we explain it again, and eventually, you know, that 1% sinks in. So anyways, so you can understand that maybe now that we see patients coming into clinic, we have the combination ROS1 ALK trial that we're looking at, and there's a very high response rate with those, but many of those patients still recur, or many of the fusion genes aren't targets of that tyrosine kinase inhibitor that's downstream from the fusion that they're trying to target. There's only 3 fusions that they are actually targeting. So other fusions that we find, it's rare to have a fusion, probably 1 to 2%, as the most might be up to 3 or 4% of cancer patients with a particular fusion. But if we find it, that's something we should also mark out in our heads to say, hey, this might be a direction to go, maybe an immunotherapy approach, you know, to qualify. You know what I mean? I don't know, but it's ways of looking at things internally. So this is the Crowley this is the Crowley synopsis, and here it's a complicated slide, but to give you a history, many know Crowley. She was diagnosed with Ewing sarcoma in 2010. She had bone metastases, a 8-centimeter pelvic lesion, had a lot of pain from her presentation, both in the back from the bone lesions and the mass that was there in the pelvic region. She had some other abdominal nodes that were involved. And she went on to traditional Ewing's treatment, which is multi-agent chemotherapy, about 5 different highly cytotoxic chemotherapy agents. She had to interrupt school, couldn't go into school during time. She was pretty sick back and forth, went in the hospital a number of times, lost all her hair, but had a complete response. So all in all, you know, the benefit was more than the risk. And did well, but she recurred within 1.3 years of her Ewing sarcoma being diagnosed. That's considered a relatively rapid recurrence. 75% of the time, kids that receive frontline treatment, where the response is probably better than 50%, they have recurrence within 2 years. If you have recurrence in 2 years, your likelihood of living 5 years is less than 10%. So that's basically where she's at, and the chance of her living 1 year is relatively poor as well. It's a little cloudy in the literature, but it's probably around 20% for 1 year with her situation. So when she recurred with a lung met. So what happened is she presented to us with multiple lung metastases. Shown on the picture there in the scan, the 812 one, that was one of her presenting lesions. But she had about 7 or 8 lung metastases. They're all relatively small, 1 to 1.5, I think the biggest is 1.8 centimeters. She was asymptomatic, but she was pretty depressed because she thought she had, gone through so much trouble with the chemo. We harvested one of the lung tumors, and were able to construct a vaccine, and she was able to go on treatment. The slide to the left of those scans show the Ellie spot response, and the arrows on the bottom show when she got a monthly injection, and so you can see what the Ellie spot response did. So we've talked about this before. Ned's probably the best person. Since he asked me a question, I'm trying to answer it. I'll ask him a question. Do you know how the Ellie spot response works? I mean, what are we doing with the Ellie spot response?
So you're taking the patient's T cells and you're exposing them to tumor antigens and seeing at baseline if they have any response to gamma interferon secretion.
Yeah.
And in her case, there was none, I guess, or less than 10 spots.
At baseline?
Yes.
Yes.
So then you give them the thing, and then you give them the vaccine, and then check the Ellie spot again to see if there is gamma interferon secretion indicating the immune cells are recognizing.
Right. So that's exactly right. And so in this situation, we're using technically mononuclear cells. Now, there's no other cell population that will give you a gamma interferon response other than T cells when they're activated and responding to an antigen. And the antigen we're using is actually the whole tumor. And that's actually a unique but important part, because typically when you use these Ellie spot assays, you use a synthesized antigen or a peptide, and it's like usually a single antigen, but we're using the whole tumor antigen. And one of the reasons for that is it really isn't known what is it on the tumor cells that creates that immune response. Is it just one dominant antigen, and if your cancer has that antigen, you get an immunotherapy, you're lucky because it's an immunostimulatory one? Or is it a whole array of antigens, related to the mutations? The antigens that the immune system is guided to attack are those that are different than what your normal body has, and so it is the mutated antigens. Now, when Foundation 1 has that report, they're reporting, 3 or 4 or 5 mutations, but that patient technically in their DNA entire code usually has 50 to 100 mutations. Each of those 100 are potential shots at a neoantigen. We just don't know which one. Work is only just started now to try to sort that out. And as we'll go on through Crowley, we may have a very, very unique window to look at that in more depth, and then an even broader window to look at about 200 patients that we've now been harvesting mononuclear cells for over time. We have long-term follow-up on survival, so we know who did well, who didn't do well, and we have tumor tissue. And so we can look at concurrently the mutation pattern, and we can look at the lymphocytes that are activated on the gamma interferon response, and we can see what are the receptors that they developed to particular antigens. We can characterize what that receptor is on a single lymphocyte, and see if it matches up with the mutated gene. And as we do that, we're going to learn what are the relevant antigens. And if we know that, we're going to then be able to apply that to therapies, to make dendritic cells that have these ligand expressions, to make T cells that have the receptors, to make antigen vaccines that have that antigen, because those are the relevant antigens. And those would be the relevant T cells and the relevant dendritic cells. That hasn't been done yet. So those are some of the things that we may be able to learn from this. It's gotten me and Neil pretty excited. And so what happened with Crowley, the reason we're a little bit extra excited, is that when you look at this Ellie spot response, she had a good brisk response. The yellow is when she was getting the treatment. The gray is when she stopped treatment, and it persists. So what we're saying is the immune system was turned on, but it didn't just come right down. When you give a PD-1 inhibitor, it'll come right down with about 2 to 3 weeks. But when you give a vaccine type approach, you generally stimulate a population of T cell effector cells, and you stimulate a subpopulation of what are called memory cells. And these memory cells persist in the body, and your activated T cells persist for a little while, but they sort of shrink down. We're going to go into this a little bit later, but the bottom line is that she was doing well, and then after about a year, a little more than a year, you can see how her Ellie spot response is coming down. And what we noticed it coming down and we were wondering what's going on. Why is it coming down? Is she stressed? What's happening? Does she need a boost? Well, we used all of the tissues that were made, and it turns out, a couple of months after it was coming down, she relapsed with disease. She developed more lung metastases. So we harvested that tissue, treated her again, and she had a second bump. There's a drop down on the 28th, like 7 months later, and we didn't see any recurrent disease there, so maybe the assay is variable. When I showed that to her and her mom, it's actually the first time I'd met her in like 28, so that's 12. That's almost 3 years I had never met her. So, yeah, conflict of interest. So it was by accident that I met her, so just don't tell Jeannie. Oh, Jeannie's here. So anyways, I didn't know who she was. So then, I'm trying to be honest. So then, here's the thing. So maybe this is too much too. But anyways, when I showed them this, but it just goes to say, when we talk to our patients, when you interact with patients, when you deal with the patients, it's not just the therapy, it's not just how well you can infuse it, it's not just a number. In her case, her and mom both, oh my God, that was December. Oh geez, that was Robbie or whatever his name was. And basically it was her boyfriend at the time, and I guess he cheated on her or something, and they broke up, and she was extremely stressed, went into depression, and it was that time. Now, was this related to that? I don't know. It's not going to be published as that, I'll tell you that. But the point is, things happen to people, and sometimes you can have regulators of the immune system, and it can relate to stress, to nutrition, things like that. So the more as we manage our patients, we can prevent things like that. I don't know where you are during that, Keisha. I mean, so we got to work on these things. But what Crowley did in 2010, when we looked at her tissue, she had an EDS-FLI type 1 gene and protein, proven very well by next generation sequencing analysis. The chromosome analysis was consistent. Then in 2012, when the first vaccine was made, her tissue was again looked at by a slightly different method, but RT-PCR. And again, the EDS-FLI type 1 was shown. It was done and compared to a cell line that was known to have EDS type 1, and that was a cell line that was used to generate a bunch of studies for the type 1 nanoplex. We wanted to just make sure that it was still relevant. Sometimes cell lines clonality change over time, but anyway, it was identical. It came up in the same spot pattern that her own did with the cell line, and so we have no doubt that she EDS-FLI type 1 Ewing sarcoma. What was odd is that in 2014, the time that we constructed the second vaccine, that recurrent disease has characteristics consistent with sarcoma. They're the same type of cell, same type of the cells, but they, guys, there's no use on the phone. Somebody has a phone thing going on. Thank you. Sorry. So anyways, when we looked at that 2014 tissue, it no longer showed EDS-FLI gene expression. So there's several possibilities. There are also about 9 other mutations with the 2010 tissue that the 2014 tissue did not have. There was a particular mutation of BRCA2 that was in both tissues, and it was the same exact mutation. So we have we know these are cancer cells, because these have been cancer cells that predated her EDS-FLI. Could they be a second primary? It still has the same point mutation. Maybe it's a germline mutation, which we think it is. So that's probably what it is. That she might have had a second point mutation. As Neil educated me on, the type of mutation that she had may relate to sensitivity and induction of cancers related to chemotherapy. Point is by following her closely, when we resected this, we were able to clear that disease spot. She went on and received the vaccine. Did the second vaccine attack that tumor antigen, or was it still with the original one? Well, it had a whole different antigen profile based on her mutation. So it's likely that the second vaccine had nothing to do in eradication of her first tumor tissue. You know what I mean? And so we're still trying to understand this. The monitor cells that were harvested on her, we're now having them looked at for the TCR expression, and we want to see, are these monitor cells from the early treatment related to EDS-FLI fusion or the other proteins that were identified on her Foundation 1 testing? And on the second tissue, were they related to the same signals as the first, or were they different signals? Well, then to what signals? And you can see how we're going to start to work out exactly what's going on in her, and if we can work that out, we'll be able to do that on any patient based on the molecular cell count. And there are 200 patients you guys and other centers have drawn blood on where we can do this work, where we have the tissue, we have the cells, and we can sort out what are the receptors these cells are attacking the cancer. So, so that's work that's going on behind the scenes. We'll have a chance to readdress sort of 6 months from now, a year from now, and why we keep registries on the patients based on their gene signals, why we harvest cells for immune work, and you know, and things like that. Are there questions? So Ned, does that help on your question with Carly?
Is she the only immune station we have that only had frontline therapy? Because I know we've got some. Am I hearing right? She only got frontline.
Yes, she was qualified for the study because she was such a high risk at recurrence within 2 years. There's other patients, all the other patients. She's the only one. There are 16 that we've treated in the phase 1/2 study. So all 15 others came on treatment after second line or more. Some of them had third line, fourth line, but yeah, she's the only front line. And she's coming in for a PET scan soon. I don't know if you heard that. Or she's not coming in here. Actually, she's doing it out at our Fort Worth.
Last results were when? From this?
What results?
The time.
CT 826. It's sooner than that.
Okay.
Today she has no evidence of disease, but she's getting a PET scan to just help us further verify. She had 3 to 8 millimeter granulomas on all our scans, even going back to 2010. So we went back and looked at those. So those, the radiologist says we can't rule out the possibility of disease, but that's been along the whole track. But that's why I want to get a PET scan to see it. So.
And did you say that some of the mutations she now has could have been caused by the chemo?
Neil, do you want to go into that? The results of the chromosome 7 and all that stuff?
Well, I mean, we don't know much about it except that on the newest, evaluation that we have for 2014, in addition to the loss of the fusion gene and obviously then of its expression, we found that chromosome 7 has a deletion at the juncture, about 1/3 of the way between the N-terminal M and the C-carboxy end. Now, the chromosome 7, we don't know specifically at this point what genes on that chromosome have been deleted, but there is an obvious deletion. One of the things we know about chromosome 7 is, one, it's associated with a number of leukemias, and 2, chromosome 7 is a chromosome that shows a lot of chemotherapy and radiation-related changes that are associated with secondary cancer. So if you treat a youngster or any individual and they develop, we'll say, a radiation cancer 15 years later, there's a reasonable chance they're going to have some type of abnormality on chromosome 7. The same is true with chemotherapy, especially alkylating agents. So in somebody who has had aggressive chemotherapy, it is possible that rather than just being a spontaneous, mutational event, this could have been a therapy-induced event. Now, this is all conjecture at this point, but it's a possibility, and we're waiting to find out, what segment of this chromosome is lost. Once we know that, we can see if previous chemotherapy and/or radiation-related chromosome 7 changes show an area of loss in this particular region of the chromosome.
So this is a rare chance when a patient with one childhood cancer, nothing to do with TMB, has immune responsiveness to immunotherapy, and over the same time period of treatment and monitoring may have had a second cancer develop. And the thing that's most rare, a bank of stored mononuclear cells where you can sort out what receptors developed on these mononuclear cells that would relate to an immune response of what may be a double response. if we can't find a Ewing sarcoma from the first, and this disease is another tumor, and we still don't have Ewing sarcoma, well then she had a complete response to that. But now we don't see this, and we don't know. We got to follow her longer, but she's out more than a year, about a year and a half now from the second tissue. And so that's an awful rare situation, and it's particularly rare to have now the stored lymphocytes to look at again for the new TCR signaling. Did they change? Did they transition with the new immunotherapy? I mean, I don't think anyone could ever plan on getting a case like this again. You know what I mean? And how much we can learn from it, how it can be used to help other people. So that's another talk. But anyways, that's why that's a remarkable case. That was really the focus of this discussion, I thought. So slide 13 is just the mechanism of the vision. I don't think it's worth going into that. We kind of explained it. Bottom line is we turn on immune cells that attack the cancer cells, and these immune cells have receptors. That's how they attack the cancer cells. The next thing is you guys have been doing these studies for a long time, so that would be fun to just share it in the sense of neoantigens. What we think we're doing is turning on the immune cells to the neoantigens. And if you look at the Ewing sarcoma patients, all the patients who were treated, it turns out 14 of the 16 patients, when they received the vigil, did indeed have turn on of their immune system. Yellow is while they were receiving the treatment. Gray is after they stopped the treatment. You can see how once they turned on, they seem to persist and stay elevated, which suggests that even though you're not getting the treatment, let's just say after the yellow, if you get something else or if you just are monitored, you're still having at least whatever protection this offers, you're still having that protection. So you can sort of use it as a way of combining with other therapies without suppressing that effect. You know what I'm saying? You get what I'm saying with that? On the left is the survival of two groups of patients. Before we added antibiotics to the regimen, when it's harvested, we had a proportion of patients that had contaminants. We also didn't know for sure what size tumor was the right size, so sometimes we had too small of a tumor sample to harvest to make, so there's insufficient tissue. Bottom line is there were 14 patients that fulfilled the same criteria as the patients who got the vigil, but these 14 patients also had the same surgery, fulfilled the same inclusion criteria, but they didn't get the product because it couldn't be made. And so the survival of those 14 patients was exactly what you would have predicted for this population of Ewing sarcoma patients. The survival of the vigil ones you can see is better. If you look on the box below, you can see the median and mean days of survival and the difference. So that appears to have correlated with the immune response. The two patients who didn't turn on their immune response both died within 6 months, one in 2 months and one in 5 months. So is it because they didn't turn on, they passed away, or was the cancer so aggressive that it was producing inhibitors that prevented it from coming on? We don't know, but you can see the limits there.
Did everybody that got vigil got at least four injections, or some of them were made that?
Not 100% sure. Most of them got all 4. I think they all did, but there may have been 1 or 2 that did, but I'm not sure.
I know a couple of them didn't get all 4, but I don't.
Yeah. My guess, obviously, those 2 down there didn't. They didn't get 4. They had 4 constructed, but they couldn't get 4. The next slide is the phase 1 data, and we had published, Neil had published this, a comparison of the first 39 patients who got vigil versus 35 who didn't. We called them matched comparators. And before we started the trial, we had to prove that it could be manufactured. And this is how you learn drug development stuff. You had to show that it could be manufactured a certain number of times consistently. So all those samples, we still tracked those patients for survival, but didn't treat them. And we looked at their survival compared to those who went on and did get the vigil. A lot of the patients in the red arm also, we couldn't construct it because they had a contaminant or something like that, and so they're concurrent to some degree. And you can see that there's differences there. The thing that was of interest is if you separate those that had the LE spot turn on and those who didn't, that's on the right. You can see the survival comparison of those 2 groups. And you can look at the days of survival. So it's not too often we get patients with refractory disease who have failed multiple prior therapies that live, 7 or 84 days. And you can see where there's tick marks, those lines cutting across, those are patients still alive. So that curve is going to continue to improve. And that's what we want to achieve. On the other curve, in the red curve, I believe there's 1 tick marks, 2 tick marks. How can you tell?
Because I see 2. Yeah.
On the red one?
Yeah.
Man, my eyes are bad. Really?
That's good eyes. Yeah.
I don't think there's pull out your glass.
Or is there one at the
I
end?
don't think so. I think it's just the.
Is that?
No, not those of the LA spot negatives.
Oh, it's the negative.
Yeah.
Oh.
Oh,
One line.
Yeah. So if
Oh,
you're LA
okay, I was
spot,
looking at
if you don't turn your LA spot, you're in bad shape. That's what I'm trying to
you're
say.
looking at the right.
Yeah.
You're looking at the left.
Yeah, I'm looking at the right when you look at the wrong. Okay, let's just be clear. So, sorry. So, all right, this is the LA spot, and this just shows what we've been showing of the 22 patients who were the LA spot positive. So it's really tracked carefully. If you look at the ovarian results, remember the ovarian randomized ovarian trial that we started, and now there's a new one going on. And this is just updated results, and you can see again the survival comparison, those who were randomized to get the Vigil and those who didn't get it. There were 10 patients. When we talked to FDA, they let us give them Vigil without having to wait for randomization. They all get Vigil after that. So it's not a total randomization, but it's a Vigil versus control. But you can see all 10 of the control patients were unable to mount any response against their tumors at baseline. And 30 to 31 Vigil patients were unable to mount any response at baseline. And but after the Vigil, all 31 did turn on. You can see the number of spots. 10 is considered positive. And the controls, after they crossed over, they had to turn on, although it was only 1/3 the level. So we don't know if that correlates with response or not, but that again shows the correlation of what the immune system can do against cancer. This just shows the 31 LH5 positives and the tracking. You can see two of them very late came down. So we're tracking why. Could it be if they got a boost, or could it be if they got combination therapy, they'd be able to keep that up and help protect them? We don't know yet.
Have you looked also at their future treatments, like if they've received more chemotherapy?
No, see, it wasn't designed to trial, and those are some of the things that it's so hard to do trials and follow for so long. But that's some of the stuff that, as you know, as we've talked about, did they get this or this? Some of them may have gotten intense chemotherapy, and then now did those 2 patients drop down? Was it because they went on? You know, it's not unusual to get doxorubicin. So, you know, what Doxil? What happened to drop those down? We don't know, and that's a limit of research when you stop following patients. So we've got to try to find ways of, in our system, be able to capture that. You know, enable consent to look back at the record, whatever it is. But those are the things that are interesting. If these are patients at our center, and they may be, we can go back and look at them. You know what I mean? With melanoma, that's an immunosensitive tumor. You can see, again, the LA spot and the survival. The melanoma control group is similar to the ovarian control group. They were not randomized, though. These are patients that had tumor resection, but didn't get it back for, again, in the early days with the contaminant or not enough tissue. And so you can see the comparison. We also show that on the next slide that if you get a low dose, a 1/10 lower than the dose we're using, you can still generate the immune response. And you can see if you look at the low dose group, there are only 12 patients that got low dose, that their survival was pretty good, 850 days and counting. But the phase 1 patients, which are similar, these were taken during the phase 1 trial. We would make an exception to allow these patients to come in. And so you can see that they had similar survival to the phase 1 patients. But the immune system is a bell-shaped curve. Sometimes when you turn the immune system on at too high a dose, you get regulators come on and balance it, and your overall response is sometimes not as good. Whereas with chemotherapy, usually the higher the better until you get to toxic effect, and then you stop in terms of anti-tumor effect comparison. So we don't know if there's something going on in the bell curve, but if you can take less tissue, you can do it with an image-guided biopsy rather than a lobectomy. You know what I mean? So that could be a useful thing to know. Combination with chemo, same thing. Now, the final 2 slides is if we have a viral infection, if you get the flu, this slide here shows that the flu virus is a pathogen. You have the pathogen increasing, dividing, growing in your body, releasing cytokines, your body tries to defend it, and you're getting sick and you feel sucky. And so eventually your immune system responds. It's pretty quick. It's within a couple of days. You can see here. This shows within about 4 or 5 days, a nexus point by which a CD8 population, specifically able to identify the pathogen, the virus, will compensate for the viral growth and start to reduce the viral numbers to the point where you no longer have symptoms. And then you're left with a residual memory population where if you get exposed to that virus again, sort of like that's why we get the tetanus shot or flu vaccine, you have a much more rapid response and a shorter course of that virus if it's the same antigens on that virus. And the reason it doesn't always work is sometimes the viruses mutate, it gets different antigens, and now the antigen with the memory that you have circulating is no longer there. Do you get all that principle? So with cancer, if you look over here, you have, here's the viral comparison where you turn on some cytotoxic T cells, you clear the pathogen, and you're left with some memory cells, that's the green yellow. Then you get a new viral infection. You have a more brisk response. You clear it faster. You're left with some memory, and that process goes on and on, okay? That's if it's the same antigen. With cancer, you get the cancer cell. You get a response to the immune system, and you are left with some memory, but the memory is not as effective. And eventually, if you have recurrence of the cancer, you'll sort of get a response, but then if you can't clear the cancer and it continues to grow, you're left with T-cell exhaustion. And so that's what we see. And so one question is there a mechanism by which we can rejuvenate the T-cell exhaustion? Could it be if we provide the gene product with the antigens of the tumor and get the immune system going again, that now we can restart this cycle? And if we potentially start to combine it with other therapies, to surgically remove the cancer, to radiate the cancer, to combine with certain therapies that don't reduce the immune system, could we actually debulk and get that revitalized immune response back? So that's kind of what the technology is trying to do. So that's really what I thought I'd go over to try to help explain what we're learning with that and give you updated results. I always liked when I was doing research, I was just waiting for the study to end so we could analyze the data and what do we really learn? I mean, we'll learn at our center, well, here's a couple of ways they did really well, or, man, it just doesn't seem to work. And all of a sudden you see all the other centers they did well. It's like that sometimes. But so far it's looking good for the responses that we're seeing, and we haven't had any issues where the samples that we stored have been irrelevant or non-usable. We're using them, and we're just now in the stage of getting these samples off to understand more of the biology, and that's what Neil and I have had a good chance to really now dive into. So,
are you finding any, with the more patients you treat, are you finding any more correlation between the number of vaccines they get and how long their early spot is?
It's sort of cheating in that sometimes patients get more vaccines because they're living longer. So we've looked at the survival and the relation of these things to all patients who got at least 4 vaccines. But when we do look at number of vaccines and we have a minimum of 4 haven't been given, we don't find any relationship. And when we look at the early spot level, between, we have to look at the median early spot, which was 134, and we look at those patients above and those patients below, we don't see any difference in survival. Now, that was done with just the 35 first phase 1 patients. Patients that are less heavily treated, like the ovarians, maybe the Ewings. As we get more numbers, we may start to find there's something breaking out. I was surprised that the crossover ovarian patients, now think about this, when they're getting it frontline and they get turned on, the ovarian patients get debulking, and they have to achieve a complete response during the chemotherapy, and then they come on to the treatment. So they have minimal to no disease. Now, 75% of these patients will relapse, but they have minimal disease. So they have minimal cancer inhibitors being produced, and then they get the visual. So, it's about your best situation for the visual to have some activity. When they relapse, they now are coming on to get the visual in the setting of relapse. So they have bulky disease. They have inhibitors being produced and all this stuff. So it's curious that the count in the minimal disease was 134, and the count in relapse was only 54. So is there a correlation with the cancer is minimizing in some way? It's still not enough to know, but that was suspicious. So Crowley's counts were in the high hundreds. So that was good. Any other questions? Is there anyone on the phone, Megan? Any questions? Or Neil? Any corrections?
Yeah, just when we talk about the number of, elder spot counts, we have to keep in mind that the effective immune response is related to, high affinity antigens where the, the presentation on, HLA class 1, has an affinity to the T cell receptor, TCR. When we do the Ellis spot, unlike a tetramer study, the Ellis spot measures high affinity and low affinity antigens, so that we have to be very careful unless we do the studies to differentiate. A high Ellis spot count may also mean that we just have a lot of low affinity antigens inducing a relatively ineffective immune response. So the number could be important, but there's a way in which it may not be important because we may be counting a lot of low affinity T cells.
Yeah, and that's probably what's so important about getting the TCR stuff going, huh?
Right.
Mm-hmm. Yeah, that's a good point, Neil. And that's what we're trying to do. We basically declared that it's just not worth trying to develop into a companion diagnostic just because of that and the assay itself is so manual, but it's giving us information to go deeper, so that's what's kind of fun. Anything else?